my colleague, I wanted to tell you today we have two very good news. Some of our colleagues that they have Viva in this week give me a very good feedback today. Really, I was so happy and I was so proud that I was included in this effort. They told me they did very well today and they will pass. Really, really, this is the best moment for me since we started 3 months ago. Uh, Thank you for all of you for your attendance. Let's start our today adult CNS cases. Our first candidate. This
Yes,
is
okay.
yes,
This
one.
is a plain CT study for
No,
single cuts.
doctor.
Okay.
Look,
Yes.
I didn't tell you the history. Okay, 45-year-old female patient presented with altered mental status and word finding difficulties.
Okay. I
I
have here
will
his inter.
scroll for you and you can stop me anywhere.
Okay, we can stop here, please.
Yes, go on.
Yes, I have presented with a multi-slice CT brain without contrast that I can see that at the level of middle cerebral artery territory at the left side there is a wedge
Okay.
shape, peripherally based cortical and subcortical hypodensity and
Yes.
with little mass effect overlying the cortical sulci. Also, there is in the caudate and lentiform nucleus. Um,
Yes.
uh, Literally, corpus striatum, there is hypodensity with little mass effect. This is and extending to coronary data and the centrum semi-oval at the level of
Excellent.
lateral ventricles. So I have also here there is a hypertense sign, a dot sign. So
Really
it looks like middle cerebral artery dot sign of left middle cerebral artery territory infarct and thalamus penetrating artery infarct.
excellent. Yeah. Give me differential. Don't
Dif-
stop. Give me a differential. First,
okay,
ask me, see. First, ask the examiner if you have a breakdown during the actual exam and the examiner is scrolling, ask him to scroll from the first slice to the bottom or to the last slice. Okay.
okay,
After
okay.
that, tell him it's a differential diagnosis and management immediately.
So management was I will contact the
No, no,
neurologist.
doctor, you didn't give me a differential diagnosis. Give me differential.
Differential differential diagnosis of could be cerebritis infection or underlying neoplastic lesion, but that is a remote differential
Or
diagnosis.
I'm not happy. I'm not happy. You describe very well. What is this?
Middle cerebral artery dense sign
What is this?
infarction. Yes,
Yes. So why you talking about cerebritis?
okay.
Yeah, go on. So your diagnosis?
Left middle cerebral artery acute infarct.
Okay, yeah, tell me management.
Management. I will ask the ask if there is a MRI brain with diffusion study to confirm the diagnosis, and I will call the interventionist neuroradiologist immediately, and if the patient will take thrombolysis or go to for thromboembolectomy.
Do you know when the patient take thrombolytic therapy, which is called atiplase, and when to into يعني refer patient to the interventional radiologist? When exactly?
TBA within 3 to 4 hours from the onset of the.
Okay, less than 4.5 hours. Okay,
Okay.
this is for thrombolytic therapy. But from the starting of symptoms, not from coming to the hospital. So
Okay.
we should ask the patient when actually you develop these symptoms. After 4.5 hours, the thrombolytic therapy has no significance. It will not يعني, utilize the patient anymore. So we will transfer the patient to intervention radiology. But doctor, what is exactly the next step in this case for you as a radiologist? What is the next radiological examination?
CT angiography sometimes
Yes, not MRI.
given
So
with
not MRI.
patient walking stroke.
Okay. See, doctor, if the patient is borderline between, يعني, we don't know exactly the
CT
time.
perfusion.
Excellent. Doctor, you are brilliant. Uh, what is in CT perfusion? What is the indicator? Yeah.
Indicator with the number sign,
Mm.
as you can see, this is
What
central
is the
blood volume
penumbra
and
sign? What is the penumbra sign?
this is the central.
Yeah.
This is the central core of actually necrotic and surrounding and differentiated from surrounding area of revascularization.
Okay.
They
So
can differentiation of cerebral blood volume and cerebral blood flow.
excellent. So in penumbra sign, we are trying to measure the amount of viable tissue and non-viable tissue. Okay.
Yes. Yeah.
Why? Because here, as you see, my friends, here, all of this hypodense, but actually, not all of this added tissue. Not all of this. What happened? If the patient, we didn't know the exact time of developing the symptoms, and we are confusing, is this patient will get a benefit from our, especially at a place, a CT or MRI perfusion done. And then, if we find any discrepancy between um, flow volume and flow rate, this is make a penumbra or this discrepancy. So yeah, what's the meaning of this, يعني, of this? If the volume actually is that, sorry, the rate is actually decreased. Okay. And the volume should be decreased also. But if the volume is not decreased, so this is an indication that there are amount of viable tissue. Okay. I will later on bring one CT brain angio to describe it practically. But I just, يعني, the question was by the way, so I asked it. Doctor, thank you so much. Really, really, you did very well. But, doctor, try if you will put a differential diagnosis list, try to put a related differential diagnosis to this case. Okay, the patient didn't have fever, and you told there are hypertension sign. So don't talk any more about cerebritis. Second of all, see, it is a territorial hypodensity, complete a territorial, no doubt. See here, what happened here? A wedge shape in the MCA distribution, and it take the left lenticuform nucleus. Okay, see, completely typical of MCA distribution. Thank you, doctor, so much. Next candidate.
Yes, sir. Assalamu alaikum.
Salam, can you request control?
Yes, I will do.
Request, please.
Yes, I did.
1 second, I will make it lesser. One second. 1 second. Don't request. I
Okay.
wanted to reduce or here. Okay. I think this is more visible, more zoomed. Okay, more larger.
Okay.
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 Request
I have
control, please.
okay. I have requested now.
Go on. 80-year-old, 60-year-old female patient presented with 1 second. Presented with sudden onset of headache for 7 days.
Okay.
Use the arrow, doctor. Use the arrow.
Hmm. Okay, I am trying. This is the MRI brain axial section in the T2 weighted image in a 60-year-old female who presented with headache for last 1 week.
Yes.
Okay. There are mildly prominent ventricles and extraventricular CSF spaces that suggest age-related cerebral atrophy. I can see an area of hyperintensity within the medulla,
Yes.
predominantly on the left side.
Yes.
Both orbits appear unremarkable. Both IC are unremarkable. I would like to see it further on diffusion weighted image.
Okay.
Can I see the diffusion weighted image?
See, don't worry about this medullary all day.
Okay.
What else?
I can see it's prominent right MCA.
Okay.
Otherwise, there is no focal lesion in the brain parenchyma.
Doctor, prominent or dilated?
It is focal dilatation.
Yes, big difference. See, doctor,
Yes,
big
focal
difference.
dilatation. Yes.
Yes. So, do you remember the history?
Yes, she has history of a headache for last 7 days.
So, what
It
is
could represent. It can represent a focal aneurysm.
okay? What else? What you are worrying about?
Um, there is no evidence of hemorrhage in the distant brain parenchyma.
Are you sure? This is the best sequence for detecting or excluding the hemorrhage in
No,
MRI.
I should check in the susceptibility weighted image.
1 second, leave the mouse.
Okay.
Go on.
Okay. This is T1 weighted image.
Yes.
So, I'm trying to scroll. There is evidence of hyperintensity along the right cerebral convexity in
Okay.
the frontal and temporal regions,
Yes.
as well as in the right sylvian fissure.
Yes.
It is T1 hyperintense, so it likely suggests hemorrhage,
Okay.
but I will confirm it on the susceptibility weighted image.
Doctor,
Yes.
do you need susceptibility in this case to confirm? Frankly.
I know T1 hyperintense are only few things: hemorrhage, proteinaceous material.
Okay. You have, see. By the way, you are right. This is your right to take or to confirm insusceptibility. But I'm speak in our daily practice. Patient
Right.
has headache, recent headache, and the
Yes.
aneurysm. And at the site of aneurysm, there are a very characteristic hemorrhage.
Hemorrhage.
See,
Yes.
what is the location of this hemorrhage?
Look, you mean it is on the it along the convexity. It appears to be subdural.
Not subdural. See, doctor.
Okay.
Doctor.
Intraparenchymal.
1 second, doctor. Doctor, by the way, you know the answer, but you are little bit hesitated. See, What is this? What is this? This one. What is this?
This is the Sylvian fissure.
When you see bleeding in Sylvian fissure, and then
Yes, subarachnoid hemorrhage.
yeah, you are correct. Don't
Yes.
hesitate. You are right.
Okay, subarachnoid
See,
hemorrhage.
doctor, you are very good, but don't hesitate.
Right.
My daily advice for most of you, the first answer in your mind almost is the best answer. Okay?
Okay.
Okay,
Okay.
you are correct. Yeah, tell me your next step.
I would like to, I would advise the angiography for this patient
Excellent.
to
And
see the size of the aneurysm, and
okay,
I would like to, I would call the interventional radiology on call for
yes.
further management.
Okay. Um, what is the commonest or the most dangerous complication of subarachnoid hemorrhage?
Most
See, by the way, this is MR angio, and this is the
right
aneurysm. Okay.
aneurysms.
What is the most critical or the worst complication of subarachnoid hemorrhage? Subarachnoid hemorrhage has many complication. By the way, this is
Okay.
gradient. See, in your
Yes,
opinion,
yes.
the T1 is more obvious and more better for showing bleeding or or gradient or
Yes,
SWI.
yes.
Look here and look here.
Right,
I think T1 is يعني more better, more easier. Okay?
right, right.
Okay, no problem. Uh, in recent bleeding or sub acute bleeding, T1 يعني will help you more than SWI. SWI will be has the upper hand when it is a chronic bleeding. Okay?
Right, right.
Upper hand. But both of them will show the bleeding. I agree with you. Anyway, what is the most critical or the worst complication of subarachnoid hemorrhage?
Um, uh, in the delayed phase, it can cause ischemia due to vasospasm.
Brilliant. Thank you, doctor.
Okay.
See, this answer, يعني very nice. Very nice. Thank you, doctor, so much.
Thank you so much, sir.
By the way, my colleague, see one of the most tricky in the brain. All of us, patient has headache, so we are searching in the parenchyma. Okay, search in the brain, no problem. If I am in your positions, I will look at the parenchyma and the ventricle, parenchyma and the ventricle, parenchyma and the ventricle, and all. And by the way, I will miss this one, no problem. Then down, nothing. The another scrolling down, search for review area. So we will divide the brain. I will not talk about anything else. Two scrolling round. First one, parenchyma and ventricle, and the most common يعني the most common structure like the subarachnoid spaces. Okay, eyes. Okay, but the most important is the second round. Look at the review areas. Okay, and start from down. Look at the skull base, including the vessels. Very critical, including the foramen magnum for any crowding, including the clivus, including everything. Your eye here only in the review areas, only the vessels. My eye is concentrated on the vessels here. Oh, okay, doctor. There are focal dilatation here. And see here, you didn't tell me, doctor, that the rest of vessels are normal because aneurysm may be multiple. This is very important. Okay?
Right, right.
Okay. So my eye here in the second round at the review areas here, sorry, here. One of the review areas is the last cut. One of my Viva was subarachnoid hemorrhage. Okay. And the pathology was here, really. Here, the last one. The examination was little bit cut, not complete examination. And there were here AVM. here at the last cut. And by the way, I confused, I concentrate at the subarachnoid hemorrhage, suppose this one. Okay, I pick up it, and then I forget to tell the examiner I will scroll at the top. I didn't pass this case. I failed in this case. Why? Because of my technique. So again and again, what we will do in Viva, first we will look at the brain and the ventricle and the most common non-review area. Okay. طب doctor, I pick up in the first round this one. Okay, no problem. Keep in mind. Keep in mind and return for review area. Why? Because maybe double pathology. It may be double pathology. Go up. I'm looking for all review areas. All review areas. Review areas, vessels. Oh, doctor. And then concentrate here. Concentrate here. Doctor, and it start to describe. The technique is the most important in Viva. Most of the people that failed Viva didn't fail because they lack of knowledge. No, 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 no. They lack either of proper technique, lack of proper training in hot seats like this, or they are hesitating character. I think uh, this is the most common causes of failing in Viva. Okay. Then please, my colleague, don't wait till the examiner asks you what is the next step or what is your management. Okay. Please tell him, doctor, the differential diagnosis is aneurysm complicated, right MCA aneurysm complicated by subarachnoid hemorrhage. Immediately I will do 1, 2, 3, 4 like this. Okay. Thank you, doctor, so much.
Just one question. Is there any pathology in the medulla?
Yes, this is lacunar infarction. All the
Lacunar infarct. Okay, old infarct. Okay.
see.
Yes, yes. T1 hypo and T2 hyper. CSF
Okay.
intensity.
I will show you here. I think this is flare. We didn't have. This is diffusion. Look here. See?
And no restriction.
Yeah.
Okay,
Okay.
thank you. Okay.
Thank you, doctor, so much. Next candidate.
Yes, sir. That's me.
Welcome. Request control, please.
Okay.
Request control.
Requested.
This is 2-year-old female patient presented with acute onset of lateral deviation of the left eye after a history of common cold.
Okay, so I'm presented with MRI of the brain, axial images T2 of a
Yes.
2-year-old child,
Yes.
presented with lateral deviation of the eye following common cold.
Yes.
I would like to have a general look before starting my comments.
Excellent.
So I will go systematically. The cerebral hemispheres are unremarkable, no hydrocephalus. The eye globes are unremarkable. The optic nerves are unremarkable. I'm not happy about the basal ganglia showing abnormal high signal intensities on both sides, which is an asymmetrical, bilateral asymmetrical, involving the medial part of the left lentiform.
Okay.
Yes, and the yes, so it's mainly the basal ganglia, the globus pallidus on the left and the right. I would like to look for other lesions, if present, which I cannot see. Vessels are, yes, there is also abnormal high signal intensity on the pons. In my routine practice, I would like to check for the sagittal and coronal views. My differential diagnosis till this point include multifocal abnormal high signal intensities could be due to infection or systemic metabolic abnormality, I would like to check for T1.
What is the next sequence? Only one sequence. Do you want only one? Ask for one.
Post contrast if available.
No post contrast. What else? If no post contrast.
Diffusion.
Diffusion. Diffusion, okay. This is the diffusion. Look.
Yes, there is high signal.
Where?
Should be in the pons again.
Yes. How you confirm
And
it is high or not? Or
I should correlate it with the ADC map.
this is ADC map. Do you think this is true
Okay.
restriction?
No, it's not restricted. It's
Okay.
still high.
So it is better to ask for flare, doctor, our doctor.
Okay.
Better.
Okay.
You find something in T2. So it is better to ask for flare or stir. This is the stir. What do you think?
Okay, the pathology is still there. So again, my differentials would be multifocal infection or demyelinating plaques.
Okay, see, the patient has a history of previous infection. Then, after the infection, he developed neurological symptoms. What is in your mind?
Adam.
Yeah, excellent, excellent. Adam. So, put Adam in the list. يعني, if infection, cerebritis, okay, I will accept. But the scenario is running about Adam. What is Adam, doctor? Would you tell me?
Well, demyelinating, yes, diffuse demyelinating, acute disseminated demyelinating leukomalacia.
Acute disseminated encephalo.
Malacia.
What?
Encephalomalacia.
Not encephalomalacia. Myelitis.
Okay.
Myelitis. So we should. What is myelitis? What mean by?
Infection of the white matter, inflammation of the white matter.
Okay, but myelitis itself.
Myelitis in the spinal cord.
Yes, so we should see the cord. What's your opinion?
Again, there are high signal intensities in the lower cord, concordant with the Adam.
Yes.
So this is an emergency to which I should call the referring physician. The patient needs
Excellent.
urgent admission and management accordingly and follow-up.
Excellent, doctor. Excellent, Dr. Anna.
Thank you.
Last question. What is from a pathological point of view? What is the difference between MS and Adam?
Adam is an immunologically mediated process.
Yes.
Okay. MS, multiple sclerosis.
Also
I'm
immunology.
not sure.
No.
Also, okay.
What?
I know that Adam, in Adam, it is all acute phase, and MS, we have different phases on the same time,
Excellent.
like acute, subacute, and chronic.
What is the name of this? Adam.
Multiphasic.
Which of them is multiphasic?
The MS is multiphasic.
Excellent. And Adam is
uniphasic. Monophasic.
Thank you, Dr. Naam, very much. My colleague, this question is very important. Why? Because MS from its name, multiple sclerosis, it has many criteria. What is the criteria? It is disseminated in time, okay? It is disseminated in location, disseminated in everything. What is the meaning of disseminated in time? What is the name? Sorry, what is it meaning? Dissemination in time means that it is polyphasic. In the same time, you can find acute, subacute, chronic plaques, MS plaques. But Adam are monophasic. All are acute, all are subacute, or are chronic. And this is very important. Why? We are examining one known patient of MS, okay? And we are sure this is a chronic. If we didn't know it may be a multiphasic, we will not search for an acute plaques. So the clinician will not increase his treatment or will not give an urgent cortisone. This is a disaster. Why? Because we didn't know scientifically this is MS is polyphasic. This is the significance of differentiation between both of them. Thank you, doctor, so much. Take care, my colleague, from the history. Take care, especially this history is very important. Without the history here, really, you can't diagnose well. Young patient has fever or common cold and then develop something neurological, visual, motor abnormality. Both add them at the top of your differential diagnosis list. Thank you so much, Dr. Anagam. Next candidate.
Hello, Assalamu alaikum.
Alaikum Assalam. Request control, please. Thank you. This patient has chronic headache. Go on.
Okay. I am provided with the sagittal T2 images of the brain showing dilatation of
See,
lateral
we
ventricle.
better start with axial. Yeah. Could you scroll?
Yes.
Scroll. Excellent.
I am provided with the T2 axial images of MRI brain showing uh, moderate dilatation of bilateral lateral ventricles uh, as well as third ventricle.
Yes.
The fourth ventricle is not significantly dilated.
Okay.
I am looking for any abnormal signal. There is subtle abnormal signal intensity area and bilateral periventricular location may indicate periventricular seepage. I cannot appreciate any abnormal signal
One
intensity area.
second. Indicate what?
Sorry.
Indicate what?
May indicate periventricular seepage.
Slippage?
Seepage, subependymal seepage.
Yeah. Okay.
Okay. There is no abnormal signal in bilateral cerebrum as well as midbrain and cerebellar hemispheres. I want to look at the sagittal images because I am thinking of site of obstruction between third and fourth ventricle.
And go on.
Yes. Sorry. Um, so I'm suspecting non-communicating hydrocephalus with site of obstruction between third and fourth ventricle. I would urgently convey my findings to a referring physician and refer this patient in neurology for management of.
You didn't tell me any finding about this sagittal. You asked for sagittal. And then tell me what do you find here?
Sir, I think so. There is aqueductal stenosis.
Aqueductal stenosis only? Okay, what is the cause of stenosis?
Yeah, there is no evidence of any mass lesion here. I think so. Yes, tactile plates appears normal. I don't think there is an enlargement of the tactile plate or any mass lesion. I can only appreciate stenosis here.
Okay, but
There is also, sir,
see,
there is also evidence of herniation of
okay,
cerebellar tonsils.
excellent. So
Yes,
don't
yes,
leave the يعني the sequence without detailing everything. This is a see, this is herniation is a fatal mistake.
yes,
Okay.
yes.
But here, see, I think one second. We are very lateral. Okay. يعني it looks like herniation. We will take
Yes.
line from Bayesian or Bayesian. It may be herniation, especially the hydrocephalus is very severe. Look at the Cephas aqueduct. Could you see this? Leave the mouse, leave the mouse. Could you see
Yes.
this? What is this?
Sir, I cannot see the mouse. Sorry.
The mouse. Here. Look here.
Yes, sir.
Here, you see the mouse?
Yes. There is a, I think so, there is a thin septum. Yes.
Okay, excellent.
Yes. There is a
So,
thin septum, which yes, it is, I think so, it is the cause of upstream hydrocephalus.
what is the name of this septum? What is the name? It has a specific name here in this location. Web. Okay? Web.
Sorry. Web.
Web.
Okay. Yes,
Web.
sir. Yes, sir. Yes.
Like web means like a net, like okay, septum, but here is very common name here. A web. Okay, doctor?
Okay.
What is your management? Tell me about the management.
Sir, as patient has developed hydrocephalus, so I would urgently refer this patient in neurology for management of hydrocephalus to relieve the pressure, and further management with or investigation with CSF flow studies can be done if needed.
Okay, do you mean that they will arrange one operation for this patient after 2, 3 days, 1, 2 weeks to treat this, or what do you mean exactly?
So I think so urgently VP shunting should be
Yes,
done.
tell me. Correct. The patient has CSF permeation, transependymal. The patient has tonsillar herniation. So it need now. The patient within 1, 2 hours maximally must be undergo must undergo a VP shunting. Okay? Okay, doctor?
Yes, sir. Okay.
Okay, thank you, doctor. You did very well, but take care from this very fine يعني mistakes. Okay? Thank you so much. This is a case of leave the mouse, please. Supratentorial hydrocephalus due to web. This is a web. Okay, my colleague. My arrow is visible for all of you or not, my colleague? دكتورة
Now it
نغم,
is
Yes, sir. Yes, it is.
visible? Okay.
yes, it is.
Okay. Thank you, doctor. This is a web. So when you are have a doubt about the syllabus of aqueduct, look inside. Look anterior, it may be thalamic glioma. Look posterior, it may be tectal plate glioma or mass or metastasis, whatever. Look at the biennial region. 1, 2, 3, 4. Four source of pathology here. Again, look here, maybe midbrain glioma, pontine anywhere, or it may be inside here, web, or tectal glioma, or a pineal region mass. Thank you, doctor, so much. Next candidate.
Yes, sir.
Request control, please.
Can you scroll for me?
Okay. This is 8-year-old female patient presented with difficulty in movement and tremors.
I have been presented with MRI, brain, T1 sequence for 8 years.
Okay.
Child presented with difficulty. Okay, I can see there is bilateral bilateral thalamic
Okay.
signal, asymmetrical, asymmetrical.
Yes.
Rest of brain appear remarkable. Can I have another sequence?
This is T2.
T2 show the abnormal signal as the low signal bilaterally with central high signal on the left side, surrounded by high signal.
Okay.
This appearance called the tiger eye.
Mm-hmm.
Tiger eye appearance.
Okay.
Mm,
What's your diagnosis?
rest of basal ganglia appear remarkable.
Mm-hmm.
White matter looks normal.
Yes.
So this is bilateral thalamic abnormal signal.
Yes.
Differential include uh, infarct,
What else?
infection,
What else?
or systemic disease, depositional disease.
Okay. See, doctor, I will help you.
Mhm,
The lesion, by the way, this is not a tiger eye. By the way,
mhm.
the lesion has a central high T2 density and the peripheral ring dark
Low
ring.
signal. Yes.
Okay. 1, 2, 3,
Yes.
4, 5,
Uh-huh.
6.
Is the
So
yes.
what you are worried about?
Calcification,
Okay, calcification. What is the next sequence do you want?
uh, SWI.
Think this is SWO.
SWI confirms the presence of signal void at
Yes.
white matter. Yeah,
Multiple signal void. Okay.
void at basal ganglia as well as
See?
white matter of
It,
supra and infratentorial.
yes, see. But
Yeah.
this signal, see, this signal drop
Mm-hmm.
or susceptibility artifact surrounded by
High signal.
okay, edema.
Yes.
So what is your differential diagnosis?
Uh, this calcification could be due to torch.
Are you sure this is calcification? Are you still, in your opinion? It may be calcification or maybe something else.
It's not high in T1, so it's likely not calcification. It was low signal in
Okay.
T1.
See in T1, see, it is surrounded by some high signal.
Yes.
Some high signal. Hmm.
Could be hemorrhage.
Excellent. Multiple hemorrhage in young
Hemorrhage.
age. Multiple focal hemorrhage, non-territorial, not related to specific distribution, and give a very characteristic appearance here. This, by the way, a very characteristic appearance for a specific disease.
Mm.
What is the differential diagnosis of multiple signal drop in MRI?
If high SWI could be hemorrhage for
Okay,
trauma like
but
axonal nerve
no history
injury,
of trauma. No history of trauma. What else?
hemorrhagic disease for vasculitis.
Okay, no vasculitis. This patient has something related to the vessel, but not vasculitis. By the way, this is called a popcorn or peri-appearance. Hmm. Peri-appearance.
Adenoma?
Excellent, excellent. It is a difficult case, don't worry. So this is a multiple cavernomas.
Adenomas.
So my colleague, in any focal hemorrhage, especially in patient not vulnerable to يعني hemorrhage, put cavernoma in top of your differential diagnosis. Okay, especially in multiple, if multiple like this. Okay, my colleague, especially. So this is a case of multiple cavernoma. My question here, what is, يعني, what should you search for in these MRIs? Something very associated with cavernoma.
Arterial,
No.
venous,
Excellent, excellent.
venous, yes, venous.
Developmental venous.
Developmental venous anomaly. هذه.
Excellent, excellent. Don't worry, don't worry. Excellent. You are excellent. No problem. Thank you, doctor, so much. It was a case of multiple cavernoma. See my colleague, the trick here. What is the trick? The patient is 8 years. Really very tricky. And this is a typical Viva scenario. What happened? He bring you very common pathology in very atypical age. Most of us expected this cavernomas in adult, young adult, and all of us diagnose it very well. Okay. By the way, doctor, my advice for you: don't insinuate yourself in يعني in uncommon signs. Tiger eye like this, like that. You can
Yes.
peripheral dark and central high. Doctor, this peripheral dark, it may indicate bleeding. So I will revise T1. Revise T1. See?
Yes.
Bleeding. Okay. See? Bleeding. This is bleeding. So doctor, give me SWI. This is SWI. Doctor, I'm worried about hemorrhagic disease. Okay, like number one, hemorrhagic metastasis. You are very good. Melanoma. Okay. A cavernoma. Or doctor, less likely to be calcified lesions like calcified cystosarcoidosis. Why this is not a calcified cystosarcosis? Why? Because the distribution here not related to blood-borne infections. Why? See, look, the blood-borne infection like neurogenic or brain cystosarcosis. Here in the junction between the cortex and white matter. Here. Okay, very characteristic. Okay, but here this is mainly in the basal ganglia or scattered. No specific pattern. Okay, doctor. We should search for developmental venous anomaly. Where here. What is this? SWR gradient T2 star here. But I think see, look with me. Look. No cobra sign. No cobra sign. Thank you, doctor, so much.
Thank you.
By the way, my colleague, all of us, even me, start our first Viva يعني with not يعني not good will. For me, I was not happy with the first, even the second session for me with our trainer, with our online trainer. But this is an experience, my colleague. So don't be sad. All of us did like you, يعني the same performance, but it is need more practice. So keep with us day by day. You will feel that you are better. All of you have the knowledge, but the hot seat is very hot, by the way. Very hot. Once you are online with the examiner, even this online session, really you are confused, you are stressed, and this is the aim of our sessions, to simulate the Viva exam. Doctor, could you request control?
Pharmacy.
Alaikum assalam. Request control, please.
Sorry, sir, I cannot control now.
Okay.
I am watching the
No
mobile.
problem, no problem. 30-year-old male patient presented with
This is axial CT brain of a 30-year-old male patient.
yes.
Non-contrast images.
Hmm.
Normal gray-white matter differentiation. There is an area
But
of
I,
hypotension noted left.
but I didn't tell you the history, doctor. I didn't tell you. The patient presented with seizure.
Yes. And there is an area of hypotension noted in left cerebral hemisphere involving white matter, subcortical and periventricular region,
Yes.
left frontal, perisylvian feature, as well as in the left temporal lobe.
Yes.
No internal calcification or hemorrhage noted. There is an area of hypotension surrounding hypervertiginous hyperintensity also noted in left basal ganglia. Also involving internal capsule and likely an internal capsule in and perisylvian extending into the perisylvian feature. It can on the basis of these images, my differential possibilities
Give
include
me some differential
viral.
diagnosis. Give me some.
It can viral encephalitis.
What else?
Viral encephalitis, gliomatosis cerebri.
Yeah.
However, these basal ganglia lesions can represent
Doctor,
some
see your
effect.
see 1 second. Your voice is little bit not clear.
Okay, sir. Now it's clear?
يعني I don't know, the mic is very near from your mouth. I think that.
Okay. It can represent herpes encephalitis or any abscess formation with marked brain parenchymal edema.
Yes. Doctor, what is the type of this edema?
MRI brain with contrast for further
What is,
evaluation.
yeah, this is better. Your voice now is better. What is the type of this edema?
This is visogenic edema.
Excellent.
So it can, sir, it can be any intraaxial mass or abscess formation.
Okay.
Further, I will go for MRI brain with contrast for further characterization. These are axial sections from T2 weighted MR brain images. There is hyperintense mass lesion noted in left basal ganglia with significant surrounding brain parenchymal edema with the resultant mass.
1 second. Vasogenic or cytotoxic?
Vasogenic edema with the resultant mass effect resulting in compression of the.
1 second. When you tell the examiner this is a vasogenic, you cut a very long way for you and for the examiner. So you are not running in the pathway of infarction.
Yes.
Okay. This is very important. So almost you are running in another way. What is this another way?
Yes. So this is vasogenic edema with resultant mass effect and subfalcine herniation.
Yes.
There is also, it shows internal necrotic area.
Okay.
I would like to see the post-contrast images. Enhancement. So it shows peripheral post-contrast enhancement with the central non-enhancing area marked edema, and there is also some meningeal thickening and enhancement also noted.
Yes.
I will see the basal region to rule out any basal meningeal enhancement. On the basis of these images, can present some tuberculous meningitis with the abscess formation.
Okay. What else?
No evidence of infarction noted. No evidence of ventriculitis seen, or it can represent some metastatic deposit.
Okay. What else?
However, internal necrotic area show. It can also show represent some septic abscess, or it can be some.
How to confirm? How to confirm an
MRS study and also diffusion restriction. I will see the. I think there is a diffusion restriction noted within the.
This is not diffusion. I gave you to
Okay,
confuse you. What is the name of this sequence? Look, look, look.
a perfusion sequence.
No.
Uh,
What is the name? See, another sequence you can see within it the vessels, especially the veins, because it is contain hemoglobin, and the hemoglobin contain iron, and the iron cause some susceptibility. So we can see the vessels because it contain iron, and the iron contains cause susceptibility. So what is the name of this sequence?
it can be cis sequence. No, it's not cis.
What? Cis? No, not cis. By the way,
Gradient echo.
I gives you the answer, by the way.
Okay, gradient echo sequence, susceptibility
Okay,
or GI.
susceptibility. Okay. My colleague, by the way, the susceptibility weighted images originally was used for venography. Why? Because they found, see, this is the veins, by the way. They find that you can draw or you can make a venography by SWI because the blood here contain iron, and the iron can cause susceptibility artifact. By the way, then later on they describe or they used to detect the bleeding. But originally, historically, I'm talking from historical point of view, SWI was and still till now is used for venography, okay, and even see here for the arteries. Anyway, but the artery here the artery didn't cause this susceptibility artifact. Anyway, this is susceptibility. See, I will show you the diffusion. I think this is diffusion.
So there is no diffusion restriction.
Give me a differential diagnosis. Number 1, number 2, 3.
It can be hemorrhagic mat,
Okay.
or other differential possibility can be it was not giving susceptibility article, so it can be not be any hemorrhage.
Okay.
Toxoplasmosis.
Excellent. Excellent. Why toxoplasmosis? What is the name of this sign?
Because it mostly involves the basal ganglia region, and it also presents with marked edema.
Yes, but what is the name of this sign?
Sorry, I couldn't
Okay.
remember.
See here in T2. What is the name of this sign? Concentric ring, concentric target sign.
Target. Okay.
Target sign. Okay, see? 2 target sign. 1, 2. Okay. Anyway, see, really, if I am in your position, I will not remember any of this. I will give a differential list. Number 1, glioblastoma, because it has a necrotic center. By the way, number 2, METS. Number 3, less likely to be infection. I'm talking frankly. Okay. So if you give the differential, especially it causes very marked edema and mass effect. Okay, so if you give a logic list of differential, the examiner will be happy. What is your management, doctor? Me.
Yes, I will refer the patient to neurosurgical team for urgent decompression and start of anti-toxoplasmosis medicine.
Okay,
Other
see
differences are also lymphoma.
here, my colleague, very obvious. 1 ring, 2 ring, concentric target sign. Okay,
Yes.
concentric target sign. Okay, this patient need urgent referral or not?
Yes, urgent referral due to this subfalcine herniation.
In your opinion, what will the team will do? What is the first line of management for them here?
They will do craniectomy and decompression surgery.
Okay, maybe correct. What else?
I think they do craniectomy for this decompression.
Okay, what else also?
Start of anti-toxoplasmosis like drugs.
Okay, but for the edema, anti-edematous measurement. Okay.
Diuretic therapy.
What?
Diuretic therapy.
Maybe. See, don't insinuate yourself in too much clinical details. If you told the examiner this patient must be given aggressive anti-edematous treatment, okay, that is more than enough. Because we don't know exactly is cortisone or Lasix or what, but at least the examiner want to assess you. Are you safe or not? You make a very brilliant diagnosis. Doctor, I like your style, really. You have a very nice self-confidence, really, really. So, and I make a lot of pressure on you by my questions, and you didn't collapse. Thank you, doctor, so much. But don't insinuate yourself in too much medical, clinical, non-radiological details. By the way, one examiner asked me about the treatment of Ewing sarcoma, about the curative percentage. My answer was that I love. I love in front of him. And she also loved. Okay. Because I don't know when the examiner asks a rare question like this, he wanted to tell you that your answer was very good. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Alaikum salam. Request control.
Yes, sir. Sir, I have requested. Okay.
40-year-old male patient presented with headache and the signs of increased intracranial tension. Yeah.
Okay. Okay. I am provided with the MRI brain of a 40-year-old male presented with signs of intracranial increased intracranial pressure and headache. These are T1 sagittal images of the same patient, and in which I can see that there are some hypointense signal return noted from the cervical cord, visualized cervical cord and the medullary region, with evidence of supratentorial mild hydrocephalus. There is also evidence of mild tentorial.
It is crawling or not? User.
I would like to see this on other sequences like T2. Okay, sir. So can I scroll? Okay. So, sir, I want to see it on T2 as well for confirmation of the lesions that I have seen in the cervical cord. To see their characteristics, because I can see that there is also swelling and edema of the cord as well.
Yes.
So this can be on these provided images. These can be demyelinating lesions, or they can be intramedullary lesions of the cord. But I would like to see on other sequences as well.
1 second, doctor. 1 second. Please, my colleague, mute yourself. There are noise. Okay, doctor, go on. Go on.
Sir, these are the same images. Can I see other sequences, please?
Sure. What sequence do you want?
T2. Okay. Okay, on T2 of the patient, there is a significant abnormal signal return noted from the brainstem as well as medulla and the cervical cord with multiple areas of flow voids also. There is a significant mass effect noted on the fourth ventricle resulting in supratentorial hydrocephalus. I would like to see if that, and I can see that there is also a heterogeneous lesion noted at the cervicomedullary region. Further, I would at this point I would keep the differential of intramedullary lesions such as hemangioblastoma. But I would, or some intramedullary other lesions such as schwannoma. But I would like to see on post-contrast images and also axial sections for further confirmation of the extent of the lesion. And I would also see the post-contrast images to see if there is any evidence of drop metastasis of the neuroaxis.
1 second. Excellent, doctor.
Okay.
Go on.
Okay, this is the post-contrast image of the same patient in which I can see that there are at least two enhancing nodular lesions noted, one at the cervicomedullary junction and one at the cervicothoracic junction in the cord, along with the significant areas of abnormal signal areas noted in the cord as well as middle cord expansion. So this my differential is the intramedullary lesions with significant cord edema and with cystic component basically. So these can be hemangioblastomas as well. And on these features, I would like to ask and I would like to see other images and do the screening of the patient for VHL, one Hippel-Lindau disease, which is associated with multiple hemangioblastomas. And in abdomen, I will see and I will look for cystic lesions in the pancreas and the liver also. Sir, and I will also do the screening of the family and the siblings also to rule out the family.
Doctor,
screening.
do you want to have a look at the brain in post contrast?
Yes, sir, please.
But why didn't you ask? The examiner will not ask you. See, Michael.
Okay.
See, will be one bad experience for me. By the way, I undergo the exam twice. One of the St. John, I named it St. John last year. The exam that has been repeated for most of the candidate. John 2024. Okay.
Okay,
And the other one, the next January this year. Anyway, the examiner, we have many, by the way, bad technical situation. So I was so
okay, sir. So can I?
One second. The examiner gave me very easy case, very easy, really. The case was
yes, sir.
Was that Mesneveau fracture, okay? Okay, and I forget to ask for the other from the stress for the other view. The examiner didn't give me, and I feel this case. See, my colleague, give me 5 minutes.
Oh.
5 minutes. You can.
Okay, sir.
Okay. Okay, so see, my colleague, this is a very nice case. Why? You are examining the brain. You have a complaint of a brain issue. Okay, then most of the disaster, yes, here something. Okay, and the most of us will talk about this, and will forget this one. This is, see, the examiner will not give you mark if you talk about hair. If you talk only about hair and they didn't mention this, he will not pass you. Really, frankly, I'm speaking. Why he bring cases, this case like this to see you if you have a satisfaction of search or not. Okay, and by the way, he at the first he will give you something axial. Okay, why to make this mistake? Okay, most of us will talk about the CSF permeation, hydrocephalus, and this left cerebellar hemispheres, and this is, by the way, too much finding, and we will forget this one. Disaster. See why? This is multiple. The cord is totally abnormal. Totally abnormal. Okay. See here. And after the contrast, see, at least 3 1, 2, 3, bile based. And this is a very characteristic of blastoma. Very characteristic. It is bile based. It is based on the bile matter. And here associated with, look, this is tear. See, marked syringomyelia. By the way, my colleague, the stair used in cord and the brain MRI. Sorry, my colleague. Hello? See, by the way, this is a stair. Stair. Very important to use the stair in the brain and the cord in case of, especially in demyelinating disease. Okay? This is a stair. How we know it? This is not only fat set. At least tell the examiner this is fluid sensitive, fat set. If you told it, okay, acceptable. But this is not the usual T2. Okay, my colleagues. Okay. So this a case of multiple bile-based markedly enhancing lesion. Here also at the brain, another one. See here, 1, 2, 3. So it looks like von Hippel-Lindau syndrome, von Hippel-Lindau disease. What is your next step? First, about the brain. We should talk about the brain because there are mass effect. See here, there are marked compression of the cerebellum. So we must talk about this at least. And then our routine usual pathway like abdominal ultrasound, rule out RCC and the family screening like this. But see here, market compression. I don't know if there are herniation here or not. No obvious herniation, but this case need at least urgent anti-edematous measurement. And then investigation for the other criteria of the syndrome. Thank you, our doctor, so much. Next candidate.